Welcome everyone to today's session of the Survivorship Series led by Dr. Flores. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the Survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center, as well as the Survivorship website. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate a Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website, www.dana-farber.org/resource center, or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Dr. Flores.
Hi, everybody. I'm delighted to be here, and I'm going to make this very realistic. I treat patients with lung cancer, and it's my true honor to be a thoracic medical oncologist. I will start saying that the only thing that is required to have lung cancer is just have one lung, not even a pair of lungs. So it affects patients of all ages, genders, backgrounds. So there's a lot of data, a lot of things that have changed about lung cancer lately, like in the last 2 weeks and in the last 10 years. But I'm going to try to group things that are general. You may have questions about specifics later too. But let's start with defining what is survivorship. And it's important to mention that we often have the perception that cancer survivorship starts after treatments are done. And the truth is the cancer survivorship starts the date the patient has the patient has a diagnosis of cancer, as they have to balance this through the entire life. The shocking news, the amount of appointments, the follow-up, living from scan to scan, the side effects of therapies, all of that is part of survivorship. My patients know that life will change forever after you hear the word cancer, and that's when you become a survivor. The needs will change over time during survivorship, like all hands on deck at the beginning of diagnosis. I see that all the time, in which patients have, a lot of support, and then, as things become more chronic, I think people go back to the regular lives, and then the very small family nucleus remains the primary caregiver to the patient. Survivorship includes physical, psychosocial, and economic sequela of the cancer diagnosis and its treatment. And when I talk about survivorship, I talk about the patients or people with lung cancer, but I also mention a lot caregivers, because as a caregiver myself to my father with cancer and my mother with cancer, cancer is a family matter. It is no happens to do one. It's a family matter. And as I'm here, I'm worried that my father, who lives with me, may make noise that's part of survivorship, right? For him. So survivorship focuses on health and well-being of that person that has been diagnosed with cancer from the time of diagnosis, but it includes physical aspects. Your body image will change due to radiation, due to chemo, due to surgery. The mental aspect, thinking about early mortality. I focus on younger women with lung cancer, and many of them have children, and they have to go and imagine things that 2 days before they will never have crossed their mind, like who will take care of my children if I die. The emotional aspect, and the emotional aspects of treatment. Some treatments are hormonal related, some treatments just make you feel awful, and for highly functional adults, that's very hard. The financial aspect cannot be forgotten. Cancer care here and everywhere in the world is very expensive. And the social aspects, particularly with the pandemic, and now we're in influenza season, a lot of my patients are limiting the social interactions because we're seeing a rise in COVID cases, influenzas around the corner. So that cancer affects all of these domains. Our patient survivorships will change as the goals of care change. Some patients may be diagnosed with early stage, they're treated with curative intent. Sometimes those patients have disease recurrence. and then the disease recurrence can remain as an early stage. The cancer can come back as metastatic. Some patients are diagnosed with metastatic cancer. So the goals of care is to try to prolong life with maintaining quality of life. And then we have the end stage or the end of the journey, also known as end of life care, in which we focus on symptoms and our patients' healthcare beliefs and goals are very important at all parts of this journey. But the journey can, and you can see the arrows, they can go up and down. And that's how my patient told me their lives are up and down. And I have some patients that don't think about me until the day before the scans, and that's the goal. I always hope that I become a memory for my patients. So what is lung cancer? So lung cancer is a type of cancer that starts in the lungs. And this is when the cells are growing out of control. People who smoke or have tobacco exposure had the greatest risk for lung cancer, though lung cancer can occur in anybody with previous tobacco exposure or not. As a focus in younger women, the number of cases of lung cancer in younger women with limited to no tobacco history continue to increase. Secondhand smoke, and we're going to talk about some of the risk factors. So lung cancer is divided in two big types, and it's based about the size of the cell. Non-small cell and then a small cell. So the non-small cell, the cells are non-small, is classified in three large groups. Adenocarcinoma, which is the most common form, and this tends to begin as often in the outside parts of the lung, outside, like the periphery of the lung. Then we have a squamous cell carcinoma that tends to cause more early symptoms because it tends to happen mostly around the bronchial tubes. So patients tend to have more symptoms with shortness of breath or wheezing. And large cell carcinoma that grows rapidly, and these also can start in the periphery. This is more rare. The more common non-small cell type is adenocarcinoma. Then we have other subtypes of non-small cell that can be a mix between adenocarcinoma and a squamous cell. The name just comes from the type of cell that originates the cancer. Sometimes it has sarcomatoid features, but these are less common. And the other big category is a small cell. A small cell is also known as oat cells, oat cell cancer back in the day, because under the microscope it looked like that. This is less common, 10 to 15%. This cancer tends to be more aggressive in percent usually when it has spread. I told my patients the cells are very small, so they travel easily compared to the other one. So let's talk about some facts about lung cancer. Lung cancer can knock anybody's door, including my nana has lung cancer, including even if your daughter is a thoracic oncologist, you still can get lung cancer. It doesn't discriminate. And she's not my biological mother, she's a woman that raised me, as an example, because we often see lung cancer as something that happens to heavy older men that have a heavy tobacco use, but it can happen to anybody, including my nana. It's estimated there's around 240,000 cases of lung cancer per year. 1 in 16 people will be diagnosed with lung cancer in their lifetime. So what are the risk factors? We know about tobacco. Tobacco use has been the risk factor and is responsible for 80%. But the frequency of tobacco use in the United States is declining, which we can see a declining number of cases in men, but in women, even with the declining use of tobacco, the cases in women are going up. When we talk about tobacco, it's not only the first smoke, but secondhand smoke is a very common risk factor. Spouses, I have patients that were flight attendants in the 70s, 60s, and 80s, so they didn't smoke, but they were literally in a tube recycling the tobacco. Tobacco use is an addiction. It shouldn't be seen as a behavior or a choice. The body develops dependency to nicotine, and despite it is very hard to quit smoking because your body gets used to it. So patients need help with smoking cessation. The second most common cause is radon gas. So radon gas is a gas that comes out of the ground. And many of us that we have bought a house in the past know that you have to check your radon. But the problem with that is that you check the radon when you buy the house, but you don't check it again. It is mostly common in the Midwest. We know asbestos exposures can do mesothelioma, but also lung cancer. Certain metals like arsenic, radiation. This is very important. Now that women are surviving a long time for breast cancer, the radiation exposures increase the risk of lung cancer. So the armpit, I have a lot of women that have armpit radiation. Air pollution is a risk factor, particularly in Asia. And a family history. This is evolving. This is not as clear as breast cancer, but it's evolving. We know that particularly for a subtype of lung cancer called EGFR, there may be a relationship with family history. All right, so I really like these mnemonics, or this way to remember the most common symptoms of lung cancer, which is breathe. So blood when you cough or speed up, are recurrent respiratory infections or pneumonias, colds that don't get better, a cough that is different or new and doesn't get better, ache in shoulder, back, or chest. The shoulder pain is very common in women as a symptom of presentation, any trouble breathing, H for hoarseness or wheezing, and E for exhaustion, feeling weak or loss of appetite. Patients can also have swelling in their neck, difficulty swallowing because there is a nerve that goes through our throat that can go all the way to the lung that can get affected by the lung cancer. So sorry, I just got paged by the hospital, so double checking everything is okay. So something important about lung cancer is lung cancer screening. Like there is a screening for breast, colorectal cancer. We also have screening for lung cancer. Unfortunately, there has not been widely adapted. This includes a low-dose CT scan. So it's a CT scan that has lower radiation than a regular CT scan. And it can decrease mortality or the chance of dying by lung cancer by 20%. It's important that you ask your doctor if you qualify for lung cancer screening, if that's right for you, because approximately 8 million Americans are at high risk for lung cancer and could benefit from lung cancer screening, but unfortunately only 6% of patients are getting screened. So it's not widely adapted or compared to breast cancer or colorectal or the pap smear. So the guidelines just changed. So who qualifies for lung cancer screening? The new guidelines is between the age of 50 or 80, if you have a 20-pack year history. What is a 20-pack year history? So that is if you smoke 1 pack a day of cigarettes daily for 20 years or more. So 1 pack or more. So for every year that you smoke 1 pack or more, it counts as a year. So 1 pack a day for 20 years. And the guidelines changed because a lot of patients before, if you quit within 15 years, you would qualify for lung cancer screening. But a lot of patients, particularly veterans that started smoking during the Vietnam War, the Korean conflict, didn't qualify because they quit smoking 20, 30 years ago. So they didn't qualify for lung cancer screening. So the guidelines just changed a week and a half ago. And the American Cancer Society now has no limit of when you quit smoking. So if you are between the age of 50 to 80 and you have smoked more than 1 pack a day for 20 years, you qualify for lung cancer screening, regardless of when you quit smoking. And this is a big deal because a lot of patients that I have seen with lung cancer would qualify for lung cancer screening, which they didn't a few weeks ago. So what happens after a lung cancer diagnosis? We need to do testing to understand if the cancer has spread anywhere else and what is the best way to treat it. The number one thing in lung cancer is the importance of doing a biopsy. So we do a biopsy to determine the type of lung cancer you have, and also biomarker testing. And we're going to talk about that in a little bit. Then we do a PET scan. A PET scan is like a radar. It's the one over here that goes to see, is there any cancer anywhere else besides the lung? Has it traveled to the liver? Has it traveled to the bone? And that allows to stage the cancer. So there are different types of treatment. When the cancer is localized, like a tumor in one part of the lung, and the patient can tolerate the surgery, then surgery is one of the first choices for treatment. Now, some patients get chemo or immunotherapy before surgery to shrink the tumor and make the surgery less aggressive, and also to avoid any of the cancer cells going and finding a new place when the patient is recovering from surgery. There are many types of surgeries, but it mostly comes to what portion of the lung is being removed. Are we doing a wedge, which is literally a wedge, a triangular version? Are we taking a segment? Are we taking an entire lobe of the lung, or are we taking the entire lung? Radiation therapy is a high-power energy beams, kind of a pinpoint X-ray that's used to treat lung cancer. It can be used for patients that have early stage that cannot tolerate the surgery. So this is a very pinpoint radiation that we treat the cancer. It also can be used in patients that have locally advanced. Their nodes, they don't have metastatic disease, but they have a lot of lymph nodes. So we treat them with chemo and radiation. And in patients in which the cancer has spread to other parts of the body, radiation can be very helpful to treat symptoms like pain when the cancer has traveled to the bone, or also in areas that in which you need local control, like eyes. My nana had eye metastasis in the choroidal area, so radiation to that area is important because it's hard to get treatment there. The radiation has many side effects, and I want to talk about some of the side effects that happen during the radiation. The number one side effect in survivorship with radiation is fatigue. Patients feel very tired. It also depends on where the size of the radiation is. If we're radiating the lungs, the number one concern is shortness of breath because of the inflammation. Also, we have the food pipe that's right in front, right behind the trachea, sometimes right behind the lymph nodes. So the food pipe gets radiated, as a side effect. So some patients can have problems swallowing. We know there's hair loss for brain radiation. Some patients can have significant nausea when they get radiation. So it's important that we support patients during the time of radiation. So because radiation not only kills the cells that are growing, but also may affect some of the healthy cells around it. So, but there is a lot of hope. And particularly lung cancer is not what it used to be. And to the people here or the people listening to this, I want you to take a message. The take-home message is that is hope. And I want you to see this graph here. The number of new lung cancer diagnoses are declining because the declining use of tobacco. But since 2006, the incidence has decreased. As I say, more in men than women, 2.6 in men, 1.1 in women. But the mortality is also decreasing, and our patients are living a very long time compared to before. It is not compared to other cancers like prostate or breast cancer, but compared to when I was training, I had patients living with metastatic lung cancer at 10 years, 12 years, 6 years, 8 years. Before it wasn't possible. And that's what I specialize a lot in, the lung cancer survivorship space, because it's a new space. We're having more and more survivors thanks to the advances in science. So we need to be ready to support patients as they recover. So we have approvals in targeted therapy, immunotherapy, and chemotherapy for lung cancer. So before we can even decide what treatment the patient will get, we need to find out if the patient has a biomarker. Lung cancer has right now 9 different approved therapies that are directed to a gene that was caused the cancer. So in order to do that, we can do 2 ways of testing. The gold standard is the tissue testing. The tissue testing is the biopsy that was taken of the tissue from the surgery, and we do genomic testing or biomarker testing. We also can do a liquid biopsy, which is a blood draw that gives you more information about if the cancer cells are circulating. You can try to do the DNA in those cells. The problem with the liquid biopsy is that not everybody has a positive liquid biopsy. Patients that have very limited disease, we have a negative biopsy because they're not sending cancer DNA to the blood. So that's what the tissue remains. But it's important. So the first message to take home is there is hope. We have hope, we have treatments. Things are changing rapidly in lung cancer. Number two is that all patients, most patients, I would say 80% of patients should get biomarker testing because that will change significantly the type of therapy that the patient will get, from a pill to an infusion. So what are the systemic therapies? Systemic means in your body that affects your entire body. There are three main therapies in lung cancer. Chemotherapy, old school chemotherapy. Targeted therapy, this is the one that targets the specific genes that cause the disease. The majority of these are pills besides one. So the patients are taking pills to control their cancer once a day, twice a day. And immunotherapy, which teaches your body to attack the cancer. So the immunotherapy itself doesn't kill the cancer, but it teaches your body, it teaches your white cells, your immune system to kill the cancer cells. So before you start any treatment, I want to encourage everybody to ask your doctor or your provider the real side effects, right? Sometimes my patients, and I've been in the other side recently and 2 years ago with my family, you're so in shock with the news and it's just a lot, right? So here's some questions you can ask if you're having a hard time understanding the side effects. Because it's important to know the side effects so you can identify early and address them. So which side effects are more likely? I always go over the most common side effects because the rare ones are there and we should discuss it, but we need to repeat over and over again the things that happen more frequently. And often they can be addressed with easy fixes. I believe in complementary medicine. I believe in things to support patient survivorship. When are these side effects most likely to happen? That's also very important. For chemotherapy, you will feel the worst between day 7 and 10 after you got the dose. For certain pills, you will feel worse after the first month. For immunotherapy, they can happen anytime. So when you should be prepared. Can you prevent some of these adverse events, some of these side effects? Certain drugs really damage the nails. So I talk to my patients about nail care, skin care to prevent them from happening. And if I have the side effects at home when I'm by myself, what can I do? What is my plan A for nausea? What is my plan B for diarrhea? And if it doesn't get better, if I have many questions, who should I call? And what is the nurse line? All hospitals have a very large directory of phone numbers, but it's very important that you collect the nurse line. As the nurses are able to, it would be fast instead of you're waiting on hold, and many of them are oncology trained nurses that will be able to help you. So what are some of the chemotherapy side effects? The short-term side effects, it means in the first month after you get chemotherapy, the most common side effects could be tingling sensations in fingers and toes, nausea and vomiting. We have a lot of medication for nausea and vomiting. I call my patients, my ladies, because I treat mostly women. I told my ladies that we're not throwing up. We are going to prevent nausea. So we can use steroids, IV medication, pills, ginger, like ginger snap, ginger tea, that will help prevent the nausea. Diarrhea or constipation can be caused by chemotherapy. It will affect your blood counts, so it can lower your platelets. It can lower your platelets, your red cells, your white cells. Fatigue, any therapy, cancer therapy will give you fatigue, and chemotherapy brings the risk of secondary cancers. When we talk about cancer therapies, we should say like a trade-off. What do I mean by trade-off? Unfortunately, there's always some type of side effect. When we say it's a trade-off, we are not surprised with a side effect. We are ready to handle them. That's what I tell my patients. We're ready to handle them. We're ready to address them. And you don't have to suffer in silence. There are many ways to treat the side effects. Chemotherapy has some long-term side effects, and chemo brain or chemo fog is a reality. Don't let nobody tell you that it's not true. It is true. I have seen it as a provider, and I see it as a patient and as a daughter. You forget where you left your keys. It's like something is over your brain, and it takes a while to clear. Even after you finish chemo, it can stay around for a while. Chronic fatigue. You can have some chronic bowel problems because the chemotherapy kills the good bacteria in your bowel. So it's very important to repopulate your bowel flora with, healthy eating afterwards. It can bring heart problems long-term, hearing loss, like ringing in the ears. Targeted therapy are these therapies that target the gene. And these are the most common side effects for all of them, but they may vary because we have 9 different treatments. So this is a general consensus. The number one is diarrhea. Most of these pills cause significant diarrhea because you have taken a pill that needs to be broken down by your GI system. Fatigue. You're going to have tiredness. You're going to feel tired. A lot of skin rashes. That's where it's very important to stay moisturized, particularly during the winter season. And if it's any skin rash that comes out, it's very important to address it right away and not letting it get worse. Mouth sores. Mouth care is very important. So I tell my patients to use sensitive toothpaste and to avoid any toothbrush that has a tongue brush in the back. Because when you're brushing your teeth, you're removing a lot of the healthy cells that are trying to repopulate in your mouth with the tongue brush. So just a soft brush, and we avoid electric toothbrushes because they can induce mouth sores, and we like to prevent it. If a mouth sore happens, baking soda mouthwashes are very miracle. They do really help. And if you have a mouth sore, avoid any mouthwash with alcohol because it will burn. We can see changes in nails. So usually I recommend my ladies to do vinegar soaks, which is 1 cup of vinegar, 1 cup of water, white vinegar from Costco or the dollar store, and you soak your nails there for 15 minutes several times per week, and it really helps with those toenails or those fingernails changes. What about immunotherapy? Well, immunotherapy can affect any organ because this is your immune system that's hyperactive. And these hyperactive white cells can attack any organ. I try to explain to my patients that is like a black sheep. There's always a black sheep in a family. So there are a few white cells that are hyperactive to the immunotherapy that may attack other organs. And the organs that really like to attack are glands. So your thyroid gland, your pancreas, they can affect your gut, produce inflammation like diarrhea. They can produce a lot of itching, eczema-like picture. Patients can have eczema-like skin. And it can produce worsening joint and muscle pain, like arthritis pain, particularly in the morning when you wake up, you feel stiff. That's how my patients describe it, stiff. And there are many things we can do to improve that. So as we talk about side effects, but as we talk about lung cancer diagnosis, it affects our patients, it affects our family members, it affects our friends or neighbors in many aspects. It has self-esteem issues, affects peer relationships, fertility, future plans. The family dynamics really get affected because it's a lot of stress, high-level conversations. It can affect career and trust in your own health and your own capacity. Let's talk about mental health needs. The mental health needs are very high in patients with lung cancer. It's estimated that around 28%, so 1 out of 4 patients with lung cancer has severe to moderate depression. And it can be a big challenge. Sometimes it's a stigma. I'm very upfront with my patients about mental health because we need to normalize mental health. Mental health, I tell my patient, depression is like blood pressure. You just need medication for it. We need to address it, destigmatize it. And there's many types of mental health needs. There's adjustment disorder. You're getting adjusted to the new normal. But it's very important to talk about solutions, the benefits of therapy. I'm on therapy, and I tell my patients I'm on therapy twice a month. I cannot focus on younger women with lung cancer without my therapist. And I couldn't get through my divorce without my therapist. I think, if we all could get a therapist, it is expensive, but it's an option that it is out there And we have psycho-oncologists at Dana-Farber. One of the unique things about surviving lung cancer is that lung cancer has a lot of stigma, and it's because of the relationship with tobacco. When a patient gets diagnosed with lung cancer and shares it with a friend or a family member, I would say 3 out of 4 times they get asked right away, do you smoke? Instead of, I'm sorry that you were diagnosed with cancer. So that just brings a lot of stigma. And I have a lot of patients that don't disclose the diagnosis to people. My Nana didn't disclose her diagnosis for 2 years. She was very afraid of the stigma, and that's very unique to lung cancer. It happens to other cancers, but I think the frequency is very high in lung cancer. This is a study that was done by the American Lung Cancer Association that shows that the percentage of people that associate lung cancer with shame was 67%. There's 1,000 people that were surveyed. 74% associate lung cancer with stigma and 75% with hopelessness. So these are very large percentage in issues, despite all advances in science. And the stigma associated with lung cancer produces isolation. You don't feel like you want to share your diagnosis, you don't have the support. It has been associated with suicidal ideation, so higher risk, because it's just that hopelessness, 75%. And the stigma has been associated with poor outcomes because often we don't seek care because we are afraid of being judged. Patients are afraid of that. And that's something very deep to lung cancer survivorship, the stigma of the disease. So what other aspects we need to talk? We need to talk about the social challenges and the responsibilities at home. I think things kind of mellow for a diagnosis, but then a lot of women and men have childcare needs. They have things at home that are still responsible when they're feeling awful from cancer. Any additional care is very expensive. Childcare, if you're responsible for your parents, other care that you have to pay to take care of your own health is extremely expensive, and it should not be forgotten. It's part of lung cancer survivorship. And safety at home, job safety, and having a place to live when you're so sick that you cannot work. The financial toxicity is very important. All these fancy treatments come to a price. All these target therapies, unfortunately, have high copays. I argue with insurance. Now, like my patients know that now it's like a sport because the insurance companies often don't really care, or they just adding more obstacles like pre-authorizations for anti-nausea medication when a patient is in chemo. And I tell my patients, we're going to pick up this and we're going to pick up the 5 and we do it. But that's extra burden. You're worried about your cancer and then you have to worry about this insurance stuff. I have a dear patient 2 months ago. She has a mutation. We needed the drug. I prescribed the drug. The drug was approved. The copay was $6,000. How are you going to tell me this is approved, but your copay is $6,000? I find that to be absurd. So I called the insurance company myself. I called the pharmacy. And they're like, whatever. It's like just trying to gaslight me. It's like, I'm going to put it in social media if you don't ship that drug to my patient in the next 2 days. Was it the right approach? I don't know. But my patient got the drug the next day. There's also higher rates of divorce and separation, particularly after all treatment has been completed. That's something that we don't talk about it. A lot of separations happens during cancer treatments and afterwards. So I'm almost coming to the end, but we need to talk about sexual health and lung cancer. 95% of patients with lung cancer, we score below 50 percentile for sexual function. And the issue with sexual health and lung cancer is that many of the issues persist even after all treatments have completed. They don't improve over time. So they need to be addressed. They're not going to get better next year. And sexual dysfunction has been associated with higher symptoms, with distress, with self-esteem issues, and sexual health should be seen as important as nausea control, as pain control, because that's part of your well-being. And when we talk about sexual health, we don't talk about intercourse and penetration. We talk about sexual health and intimacy with yourself first, And then we have partner if you have a partner. If you don't have a partner, it's still very important that self-stimulation and masturbation is part of nature. We did a large study to understand what are the reasons that were affecting sexual health in patients with lung cancer. And we noticed that fatigue, which is often underaddressed, was 40% of patients reported that was affecting their sexual health, feeling sad or unhappy, issues with their partner. We talk about high divorce rates and shortness of breath. So you can see that every domain is very different one to the other. So it's important that we talk about it. I have a bowl full of lubricant in my office just as a door to open, just as a way to open the door to talk about sexual health. Very, very funny comments. And now with Halloween, some people thought that those were actually candy. Relative, right? It can be relative. Some of those lubricant samples I have, they're chocolate mint flavor. You can call it candy. But sexuality comes in many different colors, flavors, and preferences. It starts with you. I ask my ladies to look at themselves in the mirror and tell themselves 3 sexy things they see in their body, what they like about their body. Because their body will change with the treatment with cancer. So self-stimulation and self-love is very important when it comes to sexual health. So what is the take-home message about sexual health and survivorship in lung cancer? Is that you are not bothering your doctor by asking sexual health questions. We want to empower patients to ask. If your doctor doesn't know, that we refer you to the person that knows. We have a dedicated sexual health team at Dana-Farber. And remember that a lung cancer diagnosis doesn't make your sex life and intimacy irrelevant. If you don't want to engage in sexual activity, that's also okay. It's what you feel comfortable doing. And sexuality is not only intercourse, includes cuddling, kissing, oral sex, many ways that you can express intimacy. Family and cancer, the dynamics tend to significantly change. And I think now with so many ways of communicating, sometimes patients can feel overwhelmed. So I often coach my patients about how to, thank for the health offer, but also explain that they need time for themselves. We need to remember that survivorship looks very different for everybody. I have younger women that for them, survivorship means they're going back to running. That's important to them. Going back to running, I have a patient that is a painter. She wanted to go back to painting. That was important to her. Survivorship is very different. Then I have a patient that she's Italian American, and her goal is to make supper on Sunday after Mass for her family. That's how survivorship looks for her. So we have planned all the chemotherapies on Mondays, because in that way on Sundays she feels the best, instead of giving her chemo on a Thursday or on a Friday when she would be very tired to make supper. It is really important for her to make her meatballs and spend time with her family. Survivorship looks different to everybody. Remedies are part of culture and they're part of survivorship. What is very important is that you communicate with your team if you're trying any remedies. As a Latina, we use a lot of teas, but some teas can be dangerous. They can interact with your drugs. They can bring you some new side effects. So if you're trying any remedies, it's important that you communicate with your team to make sure they're safe. But they are okay as long as you communicate and you're using safe, like ginger snaps. They really work for nausea. Caregiver education and integration is very important. And I bring this up because it's personal. And often we feel overwhelmed and we don't want to look overwhelmed in front of our family members as a caregiver. I can tell you last week, my dad and most sweet, and he wasn't doing well. And I was so strong, but I went and cried in the staircase because I didn't want him to see me cry. So that is also the fear of many of survivors, adding the burden to their family. So this is my last 2 slides. So see 6 ways in which relatives and friends can help when you have cancer. 1 is ask for help with practical tasks. Because sometimes we don't ask for help because we are afraid of feeling weak. So I have these conversations with my dad and my mom. Practical tasks. Ask for help. Can you do dishes? I don't feel good. Do the dishes. I don't feel good. I need you to do laundry. That will provide them with the sense that they're helpful, and also you will get help. bring somebody for your appointment sometimes is helpful. And now with technology, you can ask your provider if you can do it over FaceTime, if you can do it over the phone. I FaceTimes a lot of daughters because it's hard for them to take time off work. So such a, technology has been helpful there. And recognize the values of companionship. So was it yesterday? I just sat down with my dad and we watched Jeopardy. That's just being next to each other is enough sometimes. And sometimes you need to put somebody in charge of sharing your medical news, because if you send a text message, you're going to get a million text message back and you are tired. You're tired to talk about cancer. You're tired about side effects. So I have been the point person for my dad and my mom and my nana. So pointing a person can be helpful to you. And don't be afraid sometimes to open the conversation about cancer. One of my siblings will not say the word cancer. And I remember talking to him when my father was diagnosed, and he's like, oh, yeah, the disease that you treat. And this is a man with an MBA and healthcare. Yeah, he has the thing that you do. And I was like, what is the thing I do? You need to say the word. Say the word. Normalize it. And if you need an interpreter, ask for it. So my final comment is that lung cancer has many faces and doesn't discriminate. And we're here to support our patients, and we're here to learn from each other, because this is not like I told you what to do. This is you tell me what you need and we will work it out together. And if I don't know, I will ask for help, because nobody knows everything. And lung cancer survivorship can be very hard. So that's the end of my presentation.
Thank you so much, Dr. Flores. If anyone has any questions, please feel free to utilize the chat feature or put it into the Q&A, and then Dr. Flores can answer them.
And there's no crazy question and there's no stupid question. There's many things. Like, I'm a cancer doctor, and 6 weeks ago, I was literally in the doctor's office with my dad, and it's like asking us, like, what can he eat? And I felt like, but there is nothing crazy and there's no stupid questions, because you don't know. It's better to ask. Better than, that Facebook post that your aunt sent you. In Latino culture, there's always an aunt that sends a lot of Facebook misinformation via WhatsApp. So be very careful when you get your information online, because there's a multi-billion industry that tries to take advantage of patients with cancer that want to do everything they can. And sometimes a lot of these things can be harmful, and some of them are just not active. So you're using a lot of money sometimes just to be taken advantage of. So just be very careful. Ask your doctor, your nurse practitioner, anyone, if there's something that you have questions that you have seen online, because every month there's a new trend. And I have been also guilty of it. Like, I go in and look at it. It's like, what is the new thing? Is this really working? Like, what's happening? And, now with social media, those Instagram apps get you.
Well, if there are no questions, I'll just take a few moments to thank you, Dr. Flores, for a fascinating and informative program. To view the recording, please visit the Blum YouTube website, the Blum YouTube playlist, the Digital Resource Center, and the Survivorship website. This video will be posted in a few days. We want to thank you all for joining, and thank you, of course, Dr. Flores. Oh, and there's a question. So, what can help fatigue after radiation?
So there are many things that have been proven actually to help fatigue. And one of them don't make a lot of sense, but it really works, which is moderate exercise. Walking and walking-like exercises have been proven to help fatigue with radiation. You're like, but I'm tired. Why are you telling me to work out? It really works. And I know we live in an area which the weather is, but for exercise, walking outside really helps. Mild yoga exercises can also help. If you're not very stretchy, there's a lot of yoga poses that I know stretchy either, and I do it. That can also help you. Another thing that has been proven not directly with radiation, but I will discuss with your provider is ginseng. There was a study done at the Mayo Clinic that I collaborated with. American ginseng was used for cancer-related fatigue. So I will talk to your doctor about ginseng as an option, but exercise has been proven to help with that type of fatigue.
Great. And if there are no more questions, then I want to thank you again, Dr. Flores, for being here and for educating us. And thank you everyone for coming on today.